Hello, everyone. If you recall, we were able to discuss already the basic characteristics of bacteria. We had taken up bacteriology. We had taken up the basic characteristics of viruses. And then the last one that we had was on mycology, or the characteristics of fungi. Now, basing on those features or characteristic features of the different infectious agents, we are now going to discuss the organism individually, okay, by organ system. Okay, so the first organ system that we are going to discuss are those in the skin. Okay, so what are the microbial agents causing skin infections? All right, but before we go into the discussion, let us first, review the morphology or the histologic picture of the skin. Okay, if you still remember. So if you go back to the histology, we know that the skin is divided into the epidermis and the dermis, correct? And then the underneath the skin, you have the hypodermis or the subcutaneous tissues. All right, so of course after that you'll have the fascia, the muscles, and then finally the bones. So of course we know also, you still can remember that as far as the epidermis is concerned, there are divided into several zones. So from outside to inside, right? Do you remember the stratum corneum, granulosum, the stratum spinosum, and the stratum basale? All right, and then underneath that is the dermis, which is divided into two portions. You remember? We have the upper papillary, okay, and then the lower reticular, okay, and then as we had mentioned, this is the, all right, this is the subcutaneous tissue, all right, or the hypodermis. Okay, so you also notice that in the dermis, that's where the accessory organs for the skin, no, are present. So that's where the hair follicle is present. That's where sebaceous gland and the sweat glands are present. All right. So that's as far as histology. Or also, before we go into the discussion of the different infectious agents affecting the skin, we would like to mention again, we had discussed this last time, that the skin has normal microbial flora. Okay, so this is being listed previously with our lecture, but I would just like to mention a few of them, like Staphylococcus, Corynebacterium, Propionibacterium, then we have Candida, and several other organisms. And as we had mentioned, normally they're present there in the skin, and in fact, some of them can help us, all right? But again, when you disturb the physical barriers that you have, then you know that that also can provide a portal of entry for the organism. And again, the normal microbial flora can become an opportunist, right? And therefore they cause infection instead. That's say for example, there's a break in the continuity of the epithelium, for example. Okay, also I would like to mention the different skin manifestations. Now, if you have infection, what are the usual skin manifestations that you'll be able to observe? Because this will also help us decide, right, or what is the etiologic agent here. Is it a virus, is it a fungi, or is it a bacterial agent? Although you had taken this up, I know that you had taken this up in ASM, right? Okay, so we will just review them. So we have macule, papule, or you may have a combination of macule and papule, which we call as maculopapular, nodule, pustule, vesicle, bullae. Okay. And ulcer. All right. Let's start with macule. Okay, so you know that macule is flattened, right? It's a flattened discoloration in the skin. Okay, so this one is a schematic diagram, and then this picture will show us a macule. It's a flattened discoloration. This time it's reddish in appearance. Also, this one is discoloration. It's more or less reddish also, but there are some discoloration that instead of being red or hyper pigmented, they can become hypopigmented, no? So depending on the color of the skin. The second one is the papule. Of course, papule is elevated, right? It's elevated from the surface of the skin and solid, and generally 0.5 centimeters in diameter or below. Okay, so 0.5 centimeters in diameter or below. So this is how the papule will look like. So it looks like a pimple, right? So the pimple that you have, that's a papule. And as I had mentioned, when you have a combination of macule and papule, then you have maculopapular. So this one, you have maculopapular. This one also will show us a macule, and then this one is specifically pointed as a papule. So maculopapular rashes are usually seen in many viral infections, right? Like measles. Okay. Larger than a papule, no? So generally, we call it as nodule, right? If the papule or the size is about more than 5.5 centimeters in diameter. So it's a bigger solid papule. We call it as nodule. Okay, so that's a nodule there. Okay, so these are nodules. All right. Now, where do we see macule? As we have mentioned, they're seen in viral skin rashes. So there are many viral infections that will produce this type of skin rashes. It's also seen in syphilis, the secondary stage of syphilis. Papule, also seen in skin rashes. So warts actually are considered as papule, and there are staphylococcal Staph aureus infection that will also show as a papule. And then nodules also have subcutaneous present in subcutaneous mycosis, all right, and also in leprosy. Okay. Now pustule, okay, and pustule is a collection of pus, right? So pus can be composed of what you have WBC and old blood and many debris that you can have, no? So pus is a significant component of the lesion. All right, so this is a pustule. Actually, this is an infected, this is a hair follicle. Okay, so we usually refer to this as folliculitis. Okay, so this is an infection or inflammation of the hair follicles. So you see pus there, yellowish. Okay, if it becomes bigger, we call it as abscess. Okay, so this is an abscess. All right. Then vesicle and bullae. Okay, so vesicle is a smaller one, and if it becomes bigger, it is referred to as a bullae. So when you say a vesicle, it is a fluid-filled lesion. So it is blister-like. No, it is a fluid-filled skin lesion. So this, if it's small, we call it as vesicle. All right, and then if it's bigger, more than 0.5 centimeter in diameter, then we call that as bullae. All right. Now this is a skin ulcer. So when you have an ulcer, there's an excavation, right, of the skin, and this does not just occur in the skin, but it also occurs in mucous membrane. So there's an excavation or a defect, no, in the surface of the skin or surface of the mucous membrane. So that's what you call as an ulcer. All right. And then petechiae, so these are hemorrhagic manifestations. So petechiae are very small, right? It looks like a mosquito bite, no? So that's how petechiae will look like. And when it becomes bigger, it becomes a purpura, and even bigger than the purpura, you call it as ecchymosis or hematoma. Okay, so these are also found in some infection, no? That some infection that will have skin manifestations. Okay, so pustule abscess, usually it is caused by pyogenic infection, or when you say pyogenic, that means pus producing. And most of the time, it is caused by staphylococcus and streptococcus and other organisms. No? So it's not just limited, but these are the most frequent cause of pustule or an abscess formation. So staphylococcus and streptococcus. Vesicle, we mentioned vesicle is a fluid filled or a blister-like lesion. So you see this in many viral infections like herpes simplex, herpes zoster, varicella or chickenpox. Okay, so several others. So we will we will mention the type of skin lesion as we go into the discussion of individual organism. So when you say bulle, so it's bigger than a vesicle, so it is also seen in staphylococcal and streptococcal infections. All right. The ulcer is seen usually in syphilis and in chancroid. Both of these are sexually transmitted infections, so oftentimes the ulcers are seen in the genital areas, although it can also be seen in other sites. The hemorrhagic manifestations like PTK and purpura and ecchymosis is seen in meningococcemia. Right? Sometimes you can see PTK in patients with dengue infection. Okay, meningococcemia is caused by a bacteria. We call it as Neisseria meningitidis. All right. So now let's go to the microbial agents causing skin infections. Okay, so let's start with fungal agents because we had just taken up mycology. So I feel that it is better for you to be able to correlate if we start with the fungal agents causing skin infections, and then we will follow this by the bacterial agents causing skin infections, and then finally viral agents causing skin infections. So this is the pattern of the discussion that we will have when we go into organ system discussion. So we will group the etiologic agents, no? So bacterial agents, fungal agents, and then viral agents. Okay, so this is the pattern of the discussion, whatever is the organ system. All right. So let's start with the fungal agents causing skin infection. So this is a list, and when we discussed mycology, we said that the most commonly used method of grouping fungal agents is based on its major site of involvement, also referred to as clinical classification of fungal infections. No? So you have superficial mycosis, do you remember? So we listed there's a tabulation that we gave this one. Superficial mycosis, we have pityriasis versicolor, tinea nigra, and the piedras. All right. So the cutaneous mycosis, okay, so these are the dermatophytosis, which of course is derived from the term dermatophytes, right? So the etiologic agents of this group belong to the dermatophyte group. So the disease is also referred to as tiniasis. Okay, remember the three genera of dermatophytes. You remember the microsporum, the trichophyton, and the epidermophyton. And then part of the cutaneous mycosis, if you still remember, we have candidiasis. And then the third group are those causing infection in the subcutaneous tissue. No? So we call it the subcutaneous mycosis. So you'll be discussing sporotrichosis, mycetoma, and then chromomycosis. So remember that the definition that we have for mycosis is what again? Mycosis refer to fungal infection. Okay, and we already partially discussed, right, the especially the morphology of the different fungi that we had discussed. So that's why I wanted to discuss fungi first, because it's the one that we had just taken up a while ago. So do it again. So you look at the notes or the PPT, and then listen to the audio of your mycology so that you'll be able to understand the fungal agents, right, causing skin infection. So fungi will be taken up again, no, when you go to other organ system, no? So you have to remember again the characteristics of the different infectious agents, not just fungi but also bacteria and viruses. All right. So we'll start with superficial mycosis, and of course the first infection that we have here is pityriasis, also referred to as tinea versicolor. So the name of the infection is pityriasis versicolor. It is the same as tinea versicolor, and we had mentioned that this is caused by Malassezia 44. So that's the etiologic agent. So this infection is described as a chronic, non-irritating. It is a superficial lesion of the stratum corneum. And then it generally, as far as we are concerned, okay, so the color of our skin usually will result to a hypopigmented lesion. So in the more fair skin, like in Caucasians, they usually become hyperpigmented, okay? And then the lesions are found on the face, they're found on the chests, they're found on the trunk, okay, and then the abdomen. So very minimal host invasion, so and therefore minimal host response because the lesions are limited to the stratum corneum. We have shown this picture, right, in the lecture on mycology. So this is how they look like. In fact, this one now has the lesions has coalesced already, right, producing this large area of hypopigmentation. So this is found in the trunk, although as I had mentioned, it can be found on the face and the neck area, okay, in the chest and also in the abdomen. Here, these are lesions that are found on the face, all right. And you remember this one. This is the typical microscopic appearance of Malassezia 44. So when you do scraping, so when you scrape these lesions and then examine this under the microscope, so utilizing either your potassium hydroxide or you can utilize lactophenol cotton blue. So this is the one that you're able to see. So how did we describe this? Short and branched hyphae. So these are the ones. And then you have the spherical yeast cells. So these are the spherical yeast cells, and we said that they are oftentimes described as having a spaghetti and meatball appearance. Spaghetti and meatball appearance. So these are the descriptive terms that we use for the microscopic. It's very typical, no, of pityriasis or tinea versicolor. Etiologic agent is, what is the etiologic agent again? Malassezia 44. Okay, the next infection is tinea nigra, also known as tinea nigra palmaris, because it is also found in the palms of the hands, no? So the etiologic agent is Exophiala or Hirtaia wernicki. It is a dematiaceous fungi. So how did we define here dematiaceous again? Dematiaceous fungi are fungi that will produce melanin-like pigment. Do you remember? And therefore, the fungal structures are dark in color. They also produce dark colonies. Okay, and even the lesions are dark in color. Okay, so can you see this? There's a brown, okay, to black discoloration of the palms of the hand. So that's why we call it as tinea nigra palmaris. So again, the color of the lesion is dependent on this etiologic agent, which is a dematiaceous fungi. The third superficial lesions are the piedras. So piedras infect the hair shaft. So these are nodular infection of the hair shaft. There are two types of piedras. We have the black piedra and the white piedra. So obviously, the black piedra is caused by a dematiaceous fungi. So it is caused by Pedreia hortei, while the white piedra is caused by Trichosporon bigeli. So they infect not just the hair of the scalp, but they also infect the hair in the axilla, the beard, okay, or the mustache, and also in the genital areas. Okay. So this is how the white piedra will look like. So that's the hair shaft that is infected. So this is the fungi. Okay. So if you look actually at the if you look at the strand of hair that is infected, so there's a whitish structure that you see here. Actually, it looks like the knit. Can you imagine the head louse? Okay, head lice. Okay, so this is the young of the young stage of the the head lice, okay, and it's attached to the hair shaft, so this, it looks like it, okay, but this is different. It is white piedra infection of the hair shaft, and this is the black piedra, okay. So the black, yes, these are the fungal lesions, no, that you see in the hair shaft, and if you look at it closely, this is how it's going to look like. So again, piedras are infection of the hair shaft. It is caused by two organisms. One is a dematiaceous fungi, that's why you have a black piedra. We call it the infectious agent as Piedria hortae, okay, and then Trichosporum bigeli for the white piedra. So we will leave superficial. Let's now go to cutaneous mycosis. All right. So cutaneous mycosis. All right. Also referred to as dermatophytosis. Why again? Because the etiologic agents belong to the dermatophyte group. Again, how did we define dermatophytes? These are fungi that has affinity to the keratin that is present in the skin, the hair, and the nails. Okay? So these are the three genera, you remember, Microsporum species. And I mentioned here just a few of the species. There are a number of Microsporum species, but these are the significant ones causing human infection. We have Microsporum audwini, Microsporum canis, and Gypsum. All right. Trichophyton also have a lot of species, but I will just mention here the most significant ones. We have Trichophyton mentagrophyte, Trichophyton rubrum, Tonsorans, Verrucosum, and Schwenlini. All right. And for Epidermophyton, we said that there's only one species, so there's no problem. Okay, memorizing. It is Epidermophyton flocosum. All right. So reviewing, you remember this one? I gave this tabulation also before in the lecture in mycology. So again, it's a review. So there are specific sites where these dermatophytes infect. As I had mentioned, it is not absolute, okay? But in general, there are exceptions, but in general, Microsporum cause hair and skin infection. Trichophyton cause infection of the hair, the skin, and the nails. And Epidermophyton cause infection of the skin and the nail. All right. Now, these are the terms that are used to imply dermatophytosis, which are also referred to clinically as ringworms or tinea. Okay. And depending on the site where they are found, so we have Tinea capitis if it is found in the scalp, all right. Tinea barbae if it is found in the mustache or beard, it is also referred to as the barber's itch. If it is found in the body, corporis. If it is found in the inguinal area or gruen, it is also referred to as jack itch. We call it as Tinea cruris. Then if it is found in the foot, we call it as Tinea pedis, commonly known as the athlete's foot. If it is in the nails, we call it as what? Tinea ongum, or the other medical term is onychomycosis. So onychomycosis refer to fungal infection of the nail. And then if it's found in the hands, we call it as Tinea manum or manus. Okay, so that's in the hand. Now, this table will show us more or less a summary of the different species of the dermatophytes, no, that are associated with specific sites of infection. Okay, so Tinea capitis are described as circular, bald patches with broken hair, no, in the scalp. Okay, so these are the agents associated. We have Trichophyton mentagrophyte, Trichophyton tonsorans, and Microsporum canis. Then for the Tinea corporis in the body, okay, so these are also circular patches that are found in the skin with advancing red border. So what are the fungi associated with Tinea corporis? You have Trichophyton rubrum and Epidermophyton flocosum. So Tinea pedis or athlete's foot, so usually located in the interdigital spaces of the feet or in between the webs of the toes. Okay, that's the usual site. although it can extend further into the surface of the foot, the dorsal portion of the foot. So Trichosporon rubrum, Trichophyton rubrum, Trichophyton mentagrophyte, and Epidermophyton flocosum. And then for the Tinea ongum, that's the nails. So the nails become thickened, discolored, and deformed. So we have the Trichophyton rubrum, mentagrophyte, and Epidermophyton flocosum are the usual etiologic agents. Now let's look at some pictures. So this is Tinea capitis. We have shown this picture also previously. This is in the scalp. So there's bald areas, okay, patches in the scalp, and then broken hair. This is a beard, or yes, mustache, Tinea barbae. This is Tinea corporis, okay, and Tinea cruris, or this is in the inguinal area. That's Tinea pedis. All right. Tinea ongum, nails. Look at the discolored and the deformed nails. And then this is Tinea manum, or the hands. Okay. So you notice that there's an advancing border, right? And then we mentioned already previously that the best site to collect your specimen is in the edges or in the borders of the lesion, because that's where the active infection is present, and therefore you'll be able to collect your fungal structures best, no, in the peripheral or borders of the lesion. And then we also mentioned candidiasis, right, as a significant cause of cutaneous mycosis. So not just infecting the skin, it can infect the mucous membranes, it can also infect the nails, okay. So we mentioned already that Candida albicans is the most frequent species, although other species can also cause candidiasis. And we also know that Candida is a normal flora, right? It is part of the normal flora in many sites of the body. So it's a normal flora of the skin, it's a normal flora of the gastrointestinal tract, in the genitourinary tract, okay? And therefore, infections are usually endogenous in origin, meaning the organisms, when you say endogenous, the organisms are derived from normal flora that you have, that has become an opportunistic organisms when there is disruption in the normal barriers that you have, or if there is an impairment in the immune system. So we just enumerate here the different infections, Candida infections, and in both normal and immunocompromised hosts. So the usual site is in the intertriginous skin folds, no? So skin folds, so in between the fingers, and then in between the toes, then the inguinal areas, the axilla, and then one prominent area is underneath the breast, no? Especially for those individuals who are well endowed, no? So a large breast. Usually the infection loves to occur in sites that are moist, okay? Then you have onychomycosis, so this is the nails, paronychia in the fingers, okay, infection of the fingers, and then mucocutaneous junction of the lips, oral thrush, perhaps this is the most common that we observe, no? So I will show some pictures later on. Oral thrush, candidiasis, or oral candidiasis, or oral moniliasis, no? So those are the terms that are used to describe lesions in the oral mucosa. Vulvovaginitis, okay, so pulmonary infection, this is for the systemic type of infection, okay. You can also have endocarditis and meningitis for the systemic infection, and then eye infections can also occur. Fungemia and disseminated infections, of course, this is more common in patients that are immunocompromised. So onychomycosis and esophagitis. Onychomycosis and esophagitis caused by Candida albicans are very common in patients with acquired immune deficiency syndrome. In fact, this is one of the indications, especially if you have multiple oral lesions and extending into the esophagus, and therefore Candida esophagitis is one of the bad signs, no, for patients with HIV infection. And this is one of the warning clinical manifestations that the patient is going into the third and the final stage of the infection, and therefore patients are going into acquired immune deficiency syndrome state. Okay. Predisposing factors for candidiasis. So as I had mentioned, alteration in the normal skin and mucous membrane barriers. Okay, that's it. Prolonged antibiotic administration. So this is particularly true in those individuals, particularly with prolonged intake of broad spectrum antibiotics, because what's going to happen when you take broad spectrum antibiotics for a prolonged period of time, it kills the bacteria in the large bowel, right, or in the large intestine, and therefore it will disturb the normal balance that you have there. So what happens, there's a relative increase in the number of fungi, candida, that are normally present in the area, and therefore this is the one that will increase the risk of infection. The use of immunosuppressive drugs, I think that's self-explanatory, and any disease of the immune system. Okay, so that will cause suppression of the immune system. So opportunistic infections, okay. We said that candida is the most common cause of opportunistic fungal infection. So the most common species is Candida albicans. So the clinical infection is cutaneous and mucocutaneous. It can cause systemic candidiasis, or it can cause chronic mucocutaneous candidiasis. Cutaneous, especially in infants, they are highly predisposed, right? Especially if it is an infection that occurs we had mentioned this, no, infection that occurs in the perianal or perineal areas, and usually secondary to, as I mentioned, diaper rash. So when the wet diapers are not changed right away, that can actually induce the formation of diaper rash, and that site can be a focus of infection, right? So remember that candida is present in the skin, or if the mother has candida organism in the skin, then that also can be transmitted to the infant, okay, or the newborn. So in adults, normal skin usually is resistant, no, to candidal growth. So excessive skin moisture and warmth, that's the one. And trauma, or with areas with friction and abrasion, predisposed to infection. Common among dishwashers, fruit pickers, bartenders, and others. As I had mentioned, the intertriginous infections of the skin folds, toe webs, the groin, under the breast, especially in the obese. And candidiasis in adults may precede underlying endocrine problem like diabetes mellitus. So candidiasis especially in patients with diabetes mellitus. So the patient may have manifestations of vulvovaginitis, right, secondary to candida infection, or gastroenteritis, no, secondary to candida infection. So these usually occur in patients with diabetes or patients with hypoparathyroidism and Addison's disease. All right, so this is the typical oral thrush. So this is found in the inner cheek. Now, if you try to see, this is found in the oral mucosa. So I think all of us have had these lesions, no, at one time or another. So that's the oral thrush. Usually you only have a single lesion, although as I have mentioned, in immunocompromised patients, you may have multiple lesions, and it can even become ulcerated. All right. So this is the one that I have mentioned, multiple lesions. It can become ulcerated. So it does not just affect the oral mucosa. It can affect the tongue. It can affect the lips, and it can even go downwards, right? So either esophagus. Okay, that's the breasts. All right, with candida infection. Oh, we have shown this picture. So this is an infant with diaper rash that has been infected with candidiasis also. All right, so that's an infection of the nails, right? And then this is what is referred to as paronychia. So if you have an fungal infection around the nails, okay, in the fingers. All right. Now, we have already shown these pictures before, that I would just like to show it again for more emphasis. So the 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 cultures or the colonies that are produced by Candida. Okay, so it's a yeast colony. So as I had mentioned, it looks like a bacterial colony. So it also can be grown after 24 to 48 hours of incubation. Okay, so this is the description that they have. Okay, cream colored, opaque, 1 to 2 millimeters. All right. And as I had mentioned, this one, we have shown this. This is SDA. What is SDA again? It's Saborode dextrose agar. That's the yeast colony that you have there. You can also grow it on blood agar. So this is a blood agar plate, and then these are the Candida colonies. Okay. So again, showing to you the microscopic appearance. So again, if you still remember, you have the Candida albicans will show us the budding blastoconidia or blastospores. You remember that? And then the pseudohyphae. You remember the pseudohyphae? And then the chlamydospores, right? The chlamydospores. And this is the gram-positive reaction of Candida. So remember that the gram staining procedure is useful only to demonstrate Candida, and Candida has a positive reaction for. It's a beautiful gram-positive reaction. But you know, Candida is big. Okay, so the yeast cells are quite big. So even by low-power objectives, you'll be able to see this already with low-power objective. And you cannot do that for Staphylococcus, for example. So Staphylococcus has to be viewed using the oil immersion objectives. Okay. So this is PAS. So these are fungal structures stain positive with periodic acid shift. So remember, a positive PAS is red in color. This is calcofluor white. Okay, so these are the yeast cells. And these are the pseudohyphae, right? And as I had mentioned, this has to be viewed under the fluorescent microscope. Okay. Definitive diagnosis is based on a germ tube positive result. Okay, so this is the procedure for the germ tube tests. So add your test organism into a test tube containing serum, 0.5 ml sterile serum in a test tube, and then you add your test organism. So if you want to know whether the Candida organisms that you are suspecting is Candida albicans, then you do these tests, and then after that you incubate at 37 degrees Celsius for 1 to 3 hours, and after this time you just add a drop of the suspension on a slide, apply a cover slip, and then examine microscopically. So how does the germ tube look like? Okay, so that's it. It's an unstained germ tube. This is by calcofluor white, and this is by gram staining. Okay, so remember that germ tube is the only test that is definitive for Candida albicans. Okay, Candida albicans. The other species of Candida do not produce germ tube. Okay, so this is definitive for Candida. So this is the end of the first part of the lecture on skin infection. So next meeting we will continue with the rest of the fungal infections, and we're going to start with bacterial infections of the skin. Okay, so I see you then, and then stay safe, everyone.